AV blocks, Lecture 1. General overview and first degree AV block. Our module objectives: describe how an AV block forms, define AV delay, partial AV block, and complete AV block. Identify the site of delay or block in the cardiac conduction system. Identify a first degree AV block by utilizing the rules of ECG interpretation, and determine the underlying ECG rhythm in a rhythm with a first degree AV block. AV blocks are formed when conduction of the supraventricular impulses through the AV node or the ventricular portion of the electrical conduction system is either partially or completely blocked from reaching the ventricles. This overview will cover the diagnostic criteria used to identify each of the AV blocks. Our types of AV blocks include a first degree AV block, a second degree AV block, which also includes Mobitz 1 or Winkenbach, Mobitz 2, a 2-to-1 untypable, a high grade or advanced AV block, and third degree or complete AV block. So on this image here, the red indicates the potentially lethal nature of these higher degree AV blocks. And as I mentioned before, you have a delay, then you have an incomplete or partial block, and then you have a complete block, with a third degree or a complete heart block being the most serious of all the blocks. So one way to remember AV blocks: when none of the P waves are blocked, it's a first degree AV block. When some of the P waves are blocked, it is a second degree AV block. And when all of the P waves are blocked, it is a third degree AV block. AV blocks are typically caused by a conduction problem and typically show characteristic ECG patterns that involve either a prolongation of the PR interval, drop QRS complexes, or a complete pathologic lack of communication between the atria and the ventricles. Moving to the first degree AV block. First degree AV block is a conduction delay. It is not actually a rhythm itself, but it is an identifying feature of a rhythm. Remember, before we move on, you'll always have an underlying rhythm when you're identifying a first degree AV block. So it's a delay in the conduction of the supraventricular impulse to the ventricles. It's serious enough to prolong the PR interval above 0.20 seconds. So if you remember the normal rules of rhythm interpretation, your PRI should be between 0.12 seconds and 0.20 seconds. So if you see a rhythm that has a sinus P wave and a QRS, but the PRI is greater than 0.20 seconds, then it will be a first degree AV block. The delay most commonly occurs in the AV node or the bundle of His, and it prolongs the PRI. Conduction to the ventricles will occur every time. So again, this is not a block, it is a delay. So if you remember, your PR interval indicates the time it takes for the conduction to go through the atria and the small amount of time that the AV node holds up the conduction before it allows it to go into the ventricles to allow for additional ventricular overfilling and allow for the atrial kick. In this case, with a first degree AV block, you'll note that you have a much longer delay in that conduction going from the atria to the ventricles. And this occurs in the AV node. So another thing, when we're identifying the P waves, if you remember the questions that you should ask, one of the questions includes, is there a P wave for every QRS, and is there a QRS for every P wave? Each P wave in this rhythm has a QRS. Again, it's going to conduct the ventricle every time, it's just delayed. In these examples, you just see some prolonged PRIs, but they're going to be consistent across the rhythm. Your first degree AV block is not actually a dysrhythmia. I say this again because repetition leads to remembrance. It's not a dysrhythmia, it is a feature of a rhythm. Your underlying rhythm will have to be identified and then you will include first degree heart block. For instance, a sinus rhythm with a first degree AV block, or a sinus bradycardia with a first degree AV block. My rules. The rate's going to be based on the underlying rhythm. It's usually regular because the PRIs are always constant. They're just greater than 0.20 seconds. The P waves should be sinus. They should be present and upright and uniform. And because your QRS always gets a conducted beat, it should look normal. It should be 0.12 seconds or less. So here is an example of a first degree AV block. So my rate is 70 beats per minute. It is regular. My P waves, they are present and upright and similar in appearance. And my PR interval, so it is greater than 0.20 seconds. But if I were to measure every PR interval on this strip, they would all be the same amount, 0.24 seconds. This is a sinus rhythm with a first degree AV block. Your clinical significance in and of itself is of little or no significance. If you're treating a patient that happens to have a first degree AV block, most likely you're treating a sinus bradycardia or the underlying rhythm. Sometimes it occurs in the face of an acute MI, and the patient must be watched very closely, and it may signal an initial progression to a more advanced block.